By show of hands, how many in the audience have implemented telemedicine within their clinics or as a patient themselves? Telehealth, health coaching, anything remotely? Okay, good. Well, we'll keep this very interactive. This is a very exciting area. Um, what I'm going to do is kind of share with you an overview of how telemedicine's been used in the past, where it is right now from a regulatory standpoint, and also some case studies of where community health centers have implemented telemedicine and successfully, and a lot of focus on government and regulations and some of the opportunities there are from a patient efficiency standpoint and from a care coordination standpoint. There was a previous discussion about an hour ago. Some of you may have been in the patient-centered medical home, and telemedicine fits in very well into that model where you have transdisciplinary providers involved with care and having access to the same patient records. So we're going to keep this very interactive since we've got a small group. It's the end of the day especially. So I may prompt you for some questions, get some ideas from you, and I think that way we can really talk about how you might be able to implement some of the things that we're going to cover today into your regular practice. So I'm going to give you a little brief introduction about who I am and who Health Promotion Solutions is as a consulting organization. Most importantly, there's a lot of confusion about what is telehealth and what is telemedicine. Is there a difference? And what is telepresence? People are starting to hear about telepresence. I'm going to share with you what that is, which is very exciting kind of third generation telehealth. We're going to talk a lot about the benefits to the healthcare system as well as to the opportunities that are out there from a funding standpoint, both government intervention, grants, and also demonstration programs. Specifically, we're going to highlight a number of different kinds of case studies that health centers have been involved with within the community and rural health environments and also urban environments. Talk about some of the challenges, although I should give you a caveat to say many of the barriers and challenges to telehealth have been removed and been taken away, mainly because of a lot of the government initiatives. We'll also focus a lot on the opportunities for federally qualified health centers and community health centers at the end of the discussion as well. Health Promotion Solutions is a consulting organization. We've been around for about 14 years, and we do a lot of work in government agencies, nonprofit organizations, but primarily a lot of our focus is the private payers, the employers who are doing evidence-based wellness to try to document outcomes and show best practices when it comes to implementing chronic disease and prevention programs. And that's been a focus for our organization as well. From a disclosure standpoint, we have done some consulting work in the area of telemedicine. It's really been nominal, no charge for a lot of the organizations you're going to see here that we're going to highlight. But I did want to let you know that we have done some consulting work with some technology vendors, mainly because of the fact they need providers. There's all this wonderful technology out there. Home monitors, blood pressure monitors, body pulse monitors, EKG monitors on your cell phone. You can have a cell phone, put an app on your cell phone, grip it, and get an EKG reading to your physician. It's amazing, but the problem is a lot of the technology companies don't have providers. So we've been doing work with helping them identify nurse practitioners, physician's assistants, and physicians that are trained and certified to actually help with the telehealth technologies. Well, back in 1924, they had this view of a radio doctor. And if you look there, there's the young boy sticking out his tongue, and there's a visual, a television at the time, even though that was before TVs, of the doctor looking at that boy's tongue, the patient, the brother making fun of him with his tongue sticking out, and the mother probably happy that it's being taken care of, talking in some sort of large radio at the time. But amazing if someone had the foresight in 1924 to really have that vision, and we're there and we've done that before. Of course, my favorite was the Jetsons. Seeing all that technology, and when you think about it, it's 50 years, but we're not that far along. I mean, the technology's there. Now we're Skyping with our kids, but are we using it for clinical interventions? Are we providing health coaching? Are we providing counseling? Are we triaging patients so they're not going to the emergency room? And we're not. And there's really what I can share with you is a takeaway. There's really no barriers for us to be able to provide healthcare in a much more meaningful manner. using the existing technology that was envisioned 1 or 2 generations ago. So I want to clear up a little bit because telehealth is used generically. It's the umbrella for everything we're going to talk about today, but telemedicine is different. And I'll get into that in a second. But telehealth is any kind of general patient education, mobile health apps, anything that you might have on your cell phone. And it includes phones, fax, email messaging, EHR. It's what is currently being done today. So when I asked, is anyone doing telehealth? Well, you are through any of those types of mechanisms. And there's a lot of proven results with non-clinical types of telehealth. And what I'm going to suggest to you, in this pure sense of the world, telehealth is used interchangeably as telemedicine, but for now, let's segment telehealth into this whole area right here. In the world that I'm living, a lot of our clients are employers, Fortune 500 companies. For behavior change, simple phone or video Skype to get people to quit smoking, lose weight, and do those types of things. So that type of telehealth can be done in a health center environment or any type of office setting. And it's being done and paid for by a lot of the payer groups. So without clinical interventions, without having physicians or nurse practitioners or physician's assistants, many of the health coaches are doing telehealth right now using phones and getting people to do SMS text messaging on the road. For instance, the trucking industry, probably the most unhealthy population that's out there. The average life expectancy of a truck driver is age 61, and they need to pass a medical exam, the DOT exam, and they have a difficult time with it because they're so unhealthy. Well, one of the things that we're spearheading are efforts to get mobile health to these drivers and getting them a health coach. But that can be done without a physician or nurse practitioners or a PA through this type of telehealth technology. Yes, we can make them. Yeah, please don't worry about taking a lot of notes. In fact, there's a lot of text on these slides, and I apologize. In a few, you'll see. Telemedicine when it involves a physician, when it becomes a clinical experience. So from the American Telemedicine Association, they're trying to segment that fact, although I'm going to use telehealth generically to cover all of these types of things. So this would be a telemedicine experience because here would be the patient, and this would be the physician talking to that patient. The patient would have a video and be able to talk with that physician or nurse practitioner or PA, that type of thing. The third generation, which I'm going to spend a little bit of time on, is telepresence. Telepresence is when you merge the video and the technology with the actual medical instruments and create a real experience just like that physician or nurse practitioner was in the room today. And telepresence is really the next generation of telemedicine and probably what you're going to see practiced because of the advances in technology in a number of different areas. And this is telepresence. This is being launched as we speak. Right here is a medical assistant, not a nurse practitioner. This is a stethoscope. This is a Welch Allyn blood pressure monitor, spirometry instruments, EKG monitors, pulse oximeters, digital otoscope, all the types of things that would give a doctor, physician, or nurse practitioner on the other end of the screen an actual image or a heartbeat or an EKG reading that the physician could interpret. This physician is on a 3D monitor. And the difference is in a regular video Skype environment, if I'm looking that way, you may be over here. So the 3D monitor actually allows me to look everyone here in the eye, and you know I'm here as a real person, not as a video image. But this is where a lot of the telemedicine is going, because it's not about the technology, it's about the patient care. This patient is just like this doctor was in this room right as we speak. And the best part about it is it's empowering, because what this doctor is going to do in the video is split the screen, and they're going to show that patient's eardrum or their mole that's suspicious or back of their throat tonsillitis or whatever they have, and be able to show the same image that this medical assistant is providing through the skin or dermoscope. And talk about patient empowerment. When you can actually see the inside of your eardrum or inside of your throat, know that you need to take your antibiotics now, And then, by the way, after the doctor splits the screen and shows the inside of your eardrum, this doctor can push a button and actually have the pharmacist be there available to give you your counseling right at the same session. So your patient adherence can be done right at the same time. So you can actually have two different types of practitioners split the screen and actually do your counseling. So it's very empowering, and it ties into a lot of the things that we're trying to do in healthcare, which is provide engagement and better ways of empowering patients to make their own decisions. And this looks futuristic, but I can suggest to you that this model is moving forward very quickly. So there's a lot of different types of telehealth. Now I'm going to use the generic umbrella probably for the remainder of the discussion. Everything from really simple stuff to much more complicated, even robotics and ICU type things. So I'm going to use some vernacular here that throughout the presentation today that I'd like for us to be somewhat familiar with. But the simplest kind that's been done for about 20 years is the old store and forward types of messaging. So basically, I'm at a hospital, I get an x-ray or I get an MRI. That can be interpreted in Asia by a radiologist or India or Canada or whatever. Doesn't have to be in the same state. They can interpret that result. So that's the transmission of medical images for diagnosis has been going on for well over a decade, if not more. It's much better now because of bandwidth, but in years past, this has been really going on for quite a bit. The majority of type of telehealth that we've been talking about and that's being used is really just video or video type remote care, and that's the Skyping type sessions that we were basically describing as well. The big opportunity and the big growth opportunity, of course, is medical diagnosis and home monitoring. As you have known, having blood pressure or CHF or COPD or certain types of conditions can be monitored at home. EKG, you don't have to have that patient come into the physician office. This is a real advance in many rural communities, and obviously it ties into home discharge from the hospital to send people home where they wouldn't have to be coming in and monitoring. And this is a huge growth industry and a big opportunity for many of the advances in technology partners that are out there. These first three, as a sort of a summary, are really considered telemedicine, right? Because they're clinical applications. I talked a little bit about this health coaching. That's considered a form of telehealth. And then also a big area of opportunity, and you see a lot of going on right now, is teletriage, where you might have a non-clinical person just describe basic symptoms and tell you that whether you need to go in to get care or if you need some help with your insurance or whatever else. There are tremendous benefits to telehealth, telemedicine, if you will, that are self-evident. Everything from reducing travel time, no delay in getting treatment as opposed to waiting weeks in primary care with the shortages that are going to be out there or are there already. The big area, of course, is through these efficiencies is reduction in medical costs, staff and clinic costs, and indirect costs, unnecessary ER visits. Access to people that haven't gotten care before in rural communities. The biggest area, of course, for telemedicine is rural health and Indian health services that the government's been sponsoring. And there's, again, a lot of grants that have been out there and are currently out there in these areas. The big opportunity is to bring in transdisciplinary multiple specialties into a telehealth experience, and that's something that's been going on quite a bit, especially in the area of mental health. The fact that it's very educational for the consumer, being able to see a digital image, as I mentioned to you, of their skin or mole or whatever else. It ties into two big things that have been covered, of course, here is the patient-centered medical home and improvement in quality care. Everyone, it would seem to be counterintuitive that a real office visit with a real practitioner should be the standard of care. But what they're finding, and you'll see the data on these case studies where they've implemented telemedicine in a clinic environment, in a physician environment, in a hospital environment, is that people prefer it. And actually they're getting better care through telehealth than they are primary care. And some of it is the fact that there's better access to different physicians. in multiple specialties. But one of the big things, believe it or not, is communication. Because I don't know if you guys have been to your physician lately or have been to a CVS Minute Clinic or whatever else. But what you see a lot of, if you get more than 2 minutes, of course, is the clinician doing one of these. You're there, you're the patient, and they're typing all the records into the EHR system. They're not even looking at you in the eye. With telehealth, you're getting eye contact with that clinician, and you're getting, and you can see it right here. Here's the example. So part of what we're seeing in the early studies is that it's very educational. The physician or nurse practitioner or whomever the clinician is interacting with that patient, they've got their vital signs here. So the quality of care that's coming out of a telehealth type telemedicine experience is above many of the other types of traditional types of venues. And I'm going to show you case studies to share with you there. I mean, there's a lot of opportunities, obviously, from a cost-saving standpoint, but this is the part that I'm sure many of you deal with, is you have patients who may be in areas where they have to only have access to emergency rooms, and you know, this is one of the big cost drivers to our system. The fact that 65% of these ER visits are occurring after hours, and many of these individuals didn't have to go, and many of them could have been treated on very routine types of care. Even a teledoc type service could treat many of these patients. So the big issues are, will Americans embrace telehealth? Because what I can share with you, in the rest of the world, we are behind. If you go to the Middle East, if you go to Africa, if you go to many of the third world countries, by default, they've been implementing telehealth in advance of what we've done here in the States. And the statistics are showing that people are open and embracing telemedicine. 75% of Americans, through the study, suggested that they would be open to it and that they would be willing to seek care through not having a provider in the actual same room. And the question is, will this work in a community that you might deal with, in an urban or a rural population? And there's a number of studies that are documenting the fact that underserved populations are supportive of technology, even though the perception is maybe not. It's a matter of access to computers. Many patients in rural and underserved and urban environments do have mobile phones and are embracing many of the less expensive pad technologies. But a study was done and published, actually, regarding the fact that access to and comfort with technology is strong among highly underserved populations in this one particular study. So we feel that the environment is right. Maybe 3 years ago it wasn't so great. I know for a fact that when you think about it, coming on airlines, it's amazing. Everything's automated, right? Your ticket, you know, your kiosk, and soon, hopefully, getting through the lines, hopefully we'll be able to scan our IDs, which we hope, instead of that being such a manual process. But I think the world's changing, and I think more technology is going to drive that change. And President Obama and the Affordable Care Act is probably the #1 factor that's going to lead to the acceleration of telemedicine. This is going to go from a $14 billion industry to $27 billion. And it's for all the reasons we talked about. It's the home care opportunities. It's the avoidance of ER. It's going to be the physicians shortage, primary care physicians shortage. It's going to be able to create other access points to people that haven't been able to provide health care in the past before. So this is going to be an exciting area, and an area that you all are going to be involved in, if not now, very much in the future. I talked about this as far as the telehome market. Because of the hospitals wanting to get people discharged, and also that opportunity, that's that home monitoring technology as being one of the biggest growth areas. Right now, out of the telehome market, it's only 30% of all the telemedicine sales of the $14 billion, but it's going to grow to 35%. Before I go into some of the areas that are stimulating the growth and what the government's doing, and I'm going to touch on reimbursement, although by disclaimer, I'll tell you I'm not a reimbursement expert, but I can address general questions on reimbursement. Any questions about either the vernacular, about telehealth, telemedicine, or anything that I've covered so far? Yes? Mm-hmm. Mm-hmm. Yeah, mainly because of the infrastructure issues. Yeah, it's a big area. There's a question over here. Okay. Mhm. Yeah, telerobotic type procedures are being done and handled remotely by then, the surgeon or the person that would be skilled. I'm not sure in the area of oral health, but I know it is being done in other types of surgical procedures. Hmm. Hmm. Yes. Yes, that's a perfect example. And that same model is being used by remote ICU type settings where actually, the clinicians could be elsewhere, could be in another office setting, and they're monitoring that patient. So it really reduces the cost of ICU settings. So, there, yeah, there's really unlimited opportunities. We could all kind of brainstorm here with a piece of paper and pen and know that this technology is here is what could this mean to healthcare. And it's a really exciting area. But what's really important to know is the existing telehealth right now can be really implemented very simply. Really, it's really video and telephone can do so much. And I'm going to show you studies of just existing without any of the instruments, how we can make a really difference in healthcare through coaching and guidance and that type of thing. The number one fan of telemedicine, telehealth is the U.S. government by far, without a doubt, and that's exciting. And it's great to see that leadership coming. There's a number of existing grants that are currently out there. The VHA is the largest provider of remote medical services and telehealth, especially the Department of Defense and the Indian Health Services. Prisons are also have been using telemedicine for quite a while. Out in the field, military use, triage and field mobile health clinics have been around for quite a while. Medicare reimbursement, for the most part, is strong for telehealth. It's going to improve in the future. There's a number of changes going on with Medicare. Medicaid is moving very rapidly, and also private pay towards full reimbursement of telehealth. Generally, we'll get into it a little bit. There's a GT modifier on many of the costs and claims that are done through telehealth, but I'm going to share with you a lot of that is changing through some new legislation as well. And there's a number of demonstration projects that are being developed from the Center of Medicare and Medicaid Innovation. And here are some of them. So currently they're funding a lot of initiatives for this intensive care model that we were just talking about a minute ago, patient home monitoring, working with Indian Health Services, it was interesting discussion about the patient-centered medical home. I don't know if any of you are there, about the role of the medical assistant advancing and becoming more important in training and certifying that type of person. And I think that's a big area of growth where you can have people do some basic types of counseling and services as well. And then the government's been promoting the accountable care organizations, of course, which is a wonderful model for healthcare, where hospitals will be incentivized not to just have patients within their own brick and mortar. So I'm going to get into a little bit of the vernacular, and this will be helpful for you because it ties into the reimbursement discussion, but also this is something that's important as you might be looking at other types of models, and I'll get into it in a few minutes. But the terminology is the originating site, and that's actually where the eligible patient from a Medicare perspective would be located. And here are the approved locations where an originating site would be, where that patient would be getting care. That is not necessarily where the provider is. Okay, the provider would be the distant site, and this could be the commercial we saw with the nurse or the mother with the pink fuzzy slippers. And literally, it's that empowering that a person could be, generally you would want them in an office setting from a HIPAA standpoint, but it could be someone practicing out of their home as a radiologist or a clinician or a nurse practitioner or PA, and being able to provide video counseling, and they would be approved, and they could be able to support reimbursement for Medicare and for private, and also for many of the Medicaid type programs. this is going to be important, and we'll get into it a little bit later about how this might work within a community health center environment. So now I'm going to cover some case studies that that we selected that have been involved with government and federally qualified health centers and the VA. But a lot of this ties into, with this study, rural areas in the Northwest. They were able to basically save over $742,000 by having remote consultations as opposed to having the patients from the VA drive in, because they actually get compensated for travel, which I wasn't aware of. And also the fact is, of course, the ability to have better access to multiple types of physicians. They used a lot, both store forward, which was providing that interpretation remotely, as we talked about, and video conferencing as part of this study. What they also showed, again, this quality of care, empowerment. Many of the VA patients were suffering from post-traumatic stress syndrome, and they wanted to not go into the VA center because of the stigma and the emotional issues of dealing with their trauma. And they found that they actually preferred this environment and actually received better outcomes from their mental health counseling that they received, which, by the way, was one of the things I wanted to share with you. I don't know how many of you are involved with mental health type programs, but this is obviously a clear opportunity for many of those types of things, bringing in a psychologist and pharmacist and other types of transdisciplinary counselors. Of course, in the military itself, the ability to use telemedicine has been well documented to improve the care and outcomes for many of the soldiers. I'd like to now feature a couple of the federally qualified health centers that have implemented telemedicine. And this was a study specifically designed to look at traditional mental health care in a health center environment versus a transdisciplinary telemedicine model. And in the study, they recruited 364 patients that were screened for depression, and they were measuring both measuring response, remission, change in depression severity. And the traditional model was a primary care and a nurse care manager. And what they tested in this study was the ability to provide an on-site primary care and then an off-site team of nurse, pharmacist, psychologists, and a psychiatrist in this model. And the results were, in all three areas, they were able to show an increase in less severity in many of the depressive symptoms and better outcomes in this transdisciplinary approach. So I think it's validating telemedicine, but it's also validating the other point is by the ability to do things remotely, you're able to bring in all this expertise that in a traditional environment, bringing in a psychiatrist or hiring a pharmacist to come in may not be scalable. So I think that's one of the key takeaways. It really ties nicely into the patient-centered medical home. Again, I'm not an expert in mental health. Are many of you dealing with mental health patients in this manner at all through video conferencing or anything? Yes, you are. Have you found success in this model as well? Yeah? Yes. There we are. Yeah. That's good to know. And what kind of practice are you in there?
We're in San Diego.
In San Diego. Okay. California has been probably the leading state, well, besides Alaska, of course. California has really been very progressive when it's come to telemedicine type of thing. So these were mental health patients that were not cared for, but part of their treatment along the way was more video types of telecom. Oh, they were rural patients? Okay. Mm-hmm. Okay. Okay, good. Well, thank you for that feedback. The state of Georgia, this is an interesting model because I've heard other presentations of how important it is with health centers being involved in the community. But the state of Georgia received a number of grants and has expanded the program a model program, I would think, for all other states. They have 201 touch points for telehealth within the state, including schools, rural health centers, community mental health centers, group practices, hospitals, prisons. And they've created a model to create access points throughout the state for telehealth because of its rural nature as well. And what they found, and one of the key drivers they found was reimbursement. So as opposed to a modifier to get the physicians and the practitioners on board, they said, we're going to reimburse at the same rate. We're going to treat this just like a regular office visit. And that's a big trend, by the way, to see that the telehealth is actually, as opposed to other types of healthcare costs going down as far as reimbursement, what we're seeing is the opposite, is that the government is cognizant of the fact, even at the state level, that if we can make telehealth better, the efficiencies in providing that care, we're going to see the cost savings. We know it's going to work better, so we're willing to make that office visit the same, or that video virtual office visit the same. And that's what they did in the state of Georgia. They recruited 160 physicians in 40 different types of specialties. Dermatology and radiology are probably the two most important ones. And what they found is that they went from 11,000 patient visits in 1 year to 31,000. And many of them were store-forward consults where they could just remotely access the data files, and the rest of them were real-time visits. I don't have the updated 2011 data, but my understanding is that it also increased another 40%. So there are some barriers, but what I could suggest to you is that many of these barriers are either already gone away or about to go away very shortly. States really control telemedicine adoption, and there are very progressive states, like I mentioned, California, Alaska, Hawaii. There's about 14 or 15 states that allow first patient visit to not be mandatory, and I'll explain that in a second. But what it's all about is the fact that in a telemedicine experience, 35 of the states prefer that you have a relationship with that clinic or that provider already, versus the other 14 or 15 that are saying, you know what, for a number of conditions, for a lot of issues, we are comfortable that you don't have to have a relationship with that practice already, and they're allowing full reimbursement. And why I bring that up is because there's going to be there's a federal law that was just introduced in December 2012 to make that mandatory for all the states and also for physicians. Because one of the other issues with the state regulatory laws is you have to be a licensed provider in that state, which is unfortunate. So if I live in Colorado and I've got a patient in neighboring Nebraska or whatever, I can't see that patient. So state regulatory laws are certainly something we still need to deal with. Scalability is becoming less of an issue because of technology and also bandwidth. Security, obviously with EHR, it's becoming an important area, but I can share with you the latest EHR developments, and a lot of the models that I'm going to share with you are using cloud-based systems that are excellent, that really avoid a lot of the issues with this interfacing with multiple applications. So I think the world is changing to really allow a lot of these barriers to go away. So the state is really involved, and I don't want to have to read all this text, but basically they're the ones to recognize, what they deem as a real visit, and also recognize who's a practitioner. So each state could say, okay, it's okay to have a psychologist, or it may not be okay. So the states are really involved with determining that and limiting that. And then also the fact is that many of this Medicaid requirements deal with this whole issue of comparability and statewide-ness and freedom of choice. They don't apply when it comes to telemedicine. These are the 14 states that I was suggesting, and I understand there's, I believe, Maryland. Well, Maryland's already on it. I believe there's 2 more states that are about to allow this first patient visit to go away. So again, just to repeat, this would be a situation where if I came into a clinic, I would already have to have a pre-existing relationship with that clinic for me to be treated remotely. I'm going to get into the federal law in just a second, actually. Yeah, but thank you. This is a map. Again, you'll have this there, so whatever state you're in, that allows comprehensive Medicaid reimbursement. You can see that the majority of them allow for the comprehensive Medicaid reimbursement, and then most of them do allow that limited reimbursement as well. Again, I'm not an expert here, but this is the information that that I've been given in the research of Medicaid, and again, it's going to vary from state to state. But 35 states offer some sort of reimbursement for Medicaid, and again, they differentiate between an originating site and a distant site. And the originating site actually gets a facility fee, which is less than the actual distant site that the practitioner would in essence be billing. And I'm going to show some examples of where this model may be changing in the future as far as where that person could get care. And I'll give you some examples. But basically there are modifier codes that are the general rule of thumb to track telemedicine type of reimbursement. States have the flexibility with reimbursement to cover whatever types of services can be offered, what can be provided, the types of telemedicine practitioners, and how much to reimburse. This is the new legislation that's been developed by a Democrat in California. Mike Thompson introduced new legislation, I think with Governor Udall, I believe, to promote and expand the application of telehealth. And this is going to basically allow a couple different things. It's going to take away the barriers of a clinician having to be within that state to practice. So in the future, if you are in California and you're being seen, it's possible that a clinician in New York will be able to do your patient care. And that would be a tremendous success if that's able to be implemented. It's also going to support additional reimbursement measures that the federal government would like to promote as far as greater reimbursement for telehealth. This was introduced in December of 2012, and I don't know what session it's being reviewed, but the goal is that this may hopefully pass sometime this year. What I'd like to do is take a stop right here and answer any questions that have come up in any of the things that I recently presented. And then what I'd like to do is actually show you a couple different models to stimulate some ideas of where different types of telehealth might work within your practice. Any questions at this point? Okay, good. Excellent. So, the leading provider of telehealth services are organizations called Consultadoc, Teladoc, a number of different organizations, and they've been living in the private pay world. Employers have embraced this as a way to give their employees, better access to physicians at a reduced cost. And for the most part, a lot of it's been done over the phone. There's a certain amount of disease states that physicians who are trained and qualified, many of them have over 15 years experience, so they're not just a rent-a-doc kind of outfit. This is very good clinical care, and the employees, for the most part, and cash-paying customers have embraced this type of service. So I'm going to talk a little bit about Teladoc type services. Then I'm going to talk about a kiosk that is being launched called HealthSpot, and I'm actually going to show you some pictures and actually a video of what that looks like. It might stimulate some ideas. Then I'm going to share with you this telepresence, presence care kind of experience through Optimized Care Network, which is an organization that's basically customizing physician offices to provide an overflow for patient care experience and being able to provide other practitioners who could then practice remotely. And then I'll share with you some of the examples of some of the home monitoring and personal body devices. So the results from these organizations is impressive, and they've been around for quite a bit. Over 4 million users, 97% satisfaction, both from the member and from the physicians. The average consulting time is 10 minutes, which is sometimes greater than what we get with a real office setting. 91% of the issues that they deal with, which are mainly acute care kinds of things, strep throat and things like that, earaches, are dealt with in a very timely fashion. So this type of model is successful and fully embraced by many Americans. Yes? Mm-hmm. No, those are actually patients who have visited. This is actually one company called Teladoc. There's actually other competitors of them. So in the employer world, these are a nice option for people to have that might want just to get a quick consult. Now, many of them are changing over to a video consult, which I think is much better. Obviously, you can see the clinician better and allows better interaction regarding the pharmacy and your formulary and things like that. But this is well established, well received, you know, it works, and great credentials by the practitioners, and people seem to like it. And again, this is in the private pay area. Now I'm going to share with you, this organization is out of Columbus, Ohio. It has been piloted by primary care physicians. It is expanding and actually was one of the top 10 products at the CES show in Las Vegas, where they introduced thousands of new gadgets out there. And you're actually going to see an actual video from that as well. So this is a picture of a 9x5 kiosk. So from this wall to here, to this table, 9x5, and it looks like a cab, like a truck cab. In fact, the organization that actually makes it makes truck cabs, and it's sealed, it's secure, and it's a sterile environment with a UV sterilization unit inside of it. So you would walk into the clinic, and basically there would be a medical assistant or attendant outside. This person would meet and greet you, help you do your registration, do like a quick, you know, what are you here for? How can I help you type of thing. Check in, validate, sanitize, and provide patient assistance for you. But once you're inside, you're pretty much on your own. You close the door, and you have a personal consult in this very large kind of porta potty is the best way I can describe it. But you can see it's very impressive. So on the outside part, you first do your registration, and you tell the person why you're there, and so on and so forth. And it does create a record for you. And you walk in, and this is where you would sit, and over here's the screen. If you do need to do your height or weight or anything, you'd stand here. There's also a place in the back where a caregiver can sit. You know, if it's an older person, like the younger daughter or son could be there. And also, if you did need that medical assistant person from the outside, they can come in and sit right there. So, here's your weight. Here's your temperature. Again, there's different windows right here, which you'll see in the video much better, that have 8 different medical instruments. And the instruments that this organization has put in there are above and beyond what you would have at your physician. We're talking Littmann stethoscopes, the highest of the highest instruments and technology that's being used. And they're all stored in these little compartments. So blood pressure monitor comes out, and then there's a screen that explains to you what you need to do, even before you talk to the clinician now. So this is really a self-directed kiosk that, you know, picture in a retail clinic, picture in a worksite clinic, picture in a public housing environment, perhaps. There's a pulse oximeter, otoscope, dermoscope, stethoscope, spirometry instrument. I mean, there's just a litany of instruments that are out there that give real-time feedback in a digital way to both the patient and also to the clinician who's on the other end. The physician doesn't need much. They just need their Dell laptop and this camera, but this clinician controls each one of those units. So there's a software there that says, I'm going to lift open the thermometer, the thermoscope, and I want you to take it out and do this with it. So you're actually, once you get into much of the counseling, the doctor and nurse practitioner or PA would actually walk you through it. That doctor can order prescriptions, do everything online, and create your medical record just like they would in any other types of consult. But what I like about the technology is that the physician is controlling the unit. So the person's not just let there high and dry. They're actually controlling the instruments and again, being able to provide that digital image back to that patient as well. Afterwards, you get your report, and you create a medical record that you would be able to access through this organization. What they're working on, which they expect will be available this year, is an interface for all their medical records. Right now, you can just create a digital image of the record, and they don't have interface built with the Epics of the world and all that. But that's something from what we've heard that they're working on. Cleveland Clinic has just launched these in Ohio. It started in Ohio because it's state regulated. They've stayed within their home, and they've just gotten a huge amount of money from a pharmaceutical distributor to expand these nationally. Here's the list of conditions. This is very typical for many acute care. This is what you would see the teledoc service also taken care of. But again, this is a lot of the stuff that can be managed, and we don't have to clog our primary care offices or emergency rooms, that type of thing, or our health centers that you might deal with when you've got more urgently ill people. You can do the wellness checkups. There's no reason why you can't download your glucose monitor into that USB hub and your spirometry readings that are available. Blood pressure checks, diabetes monitoring. So the goal is to focus on the acute care because that's where the reimbursement is right now in this model, but then expand into more counseling, chronic disease types of wellness types of things. They piloted it in a primary care office, and basically they used it as an overflow to a primary care office. Central Ohio Primary Care, anyone from Ohio here? It's the second largest IPA in the country, independent physician practices, and 98% prefer to use over urgent care or ER, would use it again, 96%, and the age range was very high. So in their model, in their case study was a physician. The model moving forward is actually going to be nurse practitioner because that makes it more economical for them. Yep. And just from a visual schematic standpoint, I just put this together very quickly of how this type of model might work. But the question is, would this work in a situation where you might have a public housing opportunity where people wouldn't have to go into the health center? It could be used as a place or in a community type of situation. And then your practitioners ideally would be in your clinic situation, but not necessarily. They could be, evenings, weekends, home, practicing care instead of even going into the clinic in the first place. And they're seeing patients here, and it would be billable under those types of rules and regulations that are currently available. Again, this is just a schematic. I don't have the answers here, and I'm not promoting this. I have no skin in the game, but this is just one possibility of how that might look. Okay, what I'd like to do is take you on a quick tour.
In healthcare. This is a kiosk. It's a medical kiosk. It's by a company called HealthSpot. This is a great way for people who don't have easy access to healthcare to get a consultation with a doctor if they need a diagnosis or just get their vitals checked. So I'm going to show you what happens. You walk in just like you're in the doctor's office. You punch in your information here just as you would. You check and make sure that your address is right, your insurance card is right, everything that you would do in the doctor's office. Once that happens, you go inside the kiosk. So come on and I'll show you. So this is the kiosk. It looks kind of plasticky, and that's on purpose because it's much easier for them to keep clean this way. Once you're here, you sit down in the chair, and you would, again, start typing into this computer here, and you're connected to a doctor who's on the other side. Hi! Thank you. And so what happens here is you have a conversation, and you have already said whether you have a fever, whether you have a cough or a skin condition, and the doctor gets that information on the other end, correct? And so then what are you going to do? We have machines and instruments here, and you start your end of it.
Yeah, so then after you check in, you have your vital signs, you're sitting there, and explain your symptoms, that's when the fun you start using our tools, okay? So, I'll pull that out.
Okay, so let's
we can use that tool, look in your eyes, throat, to look at skin lesions. So I have to open up and say off.
Okay, so here's what happens. This opens up, and you take the instrument out, and let's see. Look at my hands, my skin.
Yeah. And then what I can also do is I can capture an image. Hold it up to your skin again. And I can take a picture, and if we see something unusual, we can mark that, and then you can take that back to your doctor or your dermatologist, and we capture that forever. So you can go ahead and put that back.
Interesting. Okay. And so you're in control of all of the instruments here, correct?
Yeah.
So we're going to grab the otoscope here. I know, this is the one that goes in your ear, right? Okay.
Have you ever seen your eardrum before?
Actually, I have not. I'm not sure I want to do this on camera, but let's see.
Oh, looks super healthy.
So,
Again, the technology allows me to take a picture of that as well.
and this would let me know if I have an ear infection, inflammation, and you could see that without my coming to your office. Okay, great.
Right.
Good. I'm going to put this back in here. Okay, and then once we're all done, you prepare something that I pick up outside, correct?
Yeah, we do a couple of things. If you need a prescription, we e-prescribe and send that electronically to your pharmacy. We always give you a paper report of your visit and any work excuse or health excuses that you might need.
Oh, great.
We have that capability.
A way to get out of school. That's great. Okay, and then so when you're all done here, you go out and you get your paperwork. But here's a really cool thing. I'm told somebody comes in after each visit and physically goes through a checklist and cleans each and every instrument in here, changes the cover, and then the whole entire room is sanitized. So this is a really great way for people who maybe are at work and don't have time to go see their doctor or just don't have great access to have a one-on-one conversation with a doctor in a very convenient way. I'm Andrea Smith for Mashable.
Good. I hope that was helpful.
What's interesting about it is all of that is available, and any one of us could have come up with that as well, because all those instruments have been around for quite a while. I'm going to share with you. Yeah, that's a good question. They've come out with some models where they're selling it into worksite clinics and retail clinics. I think at $10,000 or $15,000, not too expensive. And then there's like a monthly type of fee, like about $1,000 a month, I believe. So if you're interested in it, leave me your business card and I'll send you information from them. Again, because we don't represent them and we have no stake in the game. But we did a little consulting with them, mainly on the provider side, because they need the nurse practitioners and dietitians and health coaches on the back end. So I'm going to share with you now about a different model, which is really based on the nurse practitioners, the transdisciplinary network. So there's another company called the Optimized Care Network that's really started with the fact that it's not about the technology, it's about the care. It's about the providers. And so what they've created, though, as a result, is partnering with the best technology providers to provide that type of experience. And I was sharing with you all, what that looks like as far as that three-dimensional camera and that type of virtual experience. And what I want to do is then, before I go into it, show you what that looks like. They have a short little video that they'd sent to me in preparation for today's session as well. And I'll put that on with you.
I think healthcare reform happens at the
Can you hear that?
in the patient. And when you sit there and ask yourself, do you really love what you're doing? Are you happy with your practice right now? For me, the answer was no. Out seeing patients, not really able to sit, take my time, get to know people. I became a physician because I wanted to interact with people. I wanted to keep them healthy. And I feel like we've really lost that in the practice of medicine today. We need to revolutionize the way we're delivering healthcare to patients. We completely redesigned the healthcare delivery model to what became the Optimized Care Network. The Optimized Care Network is an organization of multidisciplinary providers, including specialty physicians, primary care physicians, nurses, case managers, pharmacists, social workers, dietitians, therapists, all coming together at the convenience of the patient. No more does the patient have to drive from location to location to receive exceptional care. They can come to one location in their hometown and be cared for by the best doctors, case managers, nurses in the world, and really receive what we define as exceptional care. It's patient-centered and patient-focused. We've coalesced some of the greatest technologies in healthcare to to bring a three-dimensional image of the physician directly to the patient. We want the technology to be as transparent for you as it is for the patient. Everything we've designed is to make it simple, easy to set up, easy to use, and all cloud-based. It'll be an exciting way to connect with the patient. We eliminated all of the need to do documentation, as the nurse that's in the room will provide the documentation for the healthcare provider. We want to really be able to engage with the patient, to spend the time to sit, to get to know them, and to interact with them in a way that's never been done before. We see the technology as a road, not as the destination. The destination is exceptional healthcare. Redesigning the way we deliver healthcare in a way that's personal and interactive is exciting to me. If you're excited about the idea of revolutionizing healthcare and changing those delivery models, and once again enjoying the practice of medicine, then we want you to come and be a part of the Optimized Care Network.
So the difference with, there's two different models, and I'm glad I had the opportunity to share both of them with you. The one is where potentially a health center would have your clinicians in one site, right? In essence, you would be the distant site where the health spot unit would be actually where the patients are, the originating site. So that could be actually a challenge from a reimbursement standpoint, the way Medicaid laws are right now, right? So the care is at the patient's actually in that model at a remote site. Let's say it was a public housing environment. If that kiosk was put into a federally qualified health center, that would be different, which would be then the originating site, the patient is actually there where they're being treated, right? But the distant provider could be practicing at home or practicing in an office setting. So I just wanted to clarify that. With these folks, with the Optimized Care Network, what they're doing is saying, we want to come in where you have too many patients. We want to, their model is, I'm going after doctors' offices where they're just too busy and they need better care. They need an overflow. So in this model, in essence, they would be taking a room, let's say in a health center, and putting a three-dimensional camera and putting all the equipment in there and that type of thing. And your providers wouldn't have to actually then physically be into that health center. So it's two different models, but I wanted to share that with you because really that's where you know, a lot of this, you know, needs to be thought through as you're building your models out as well. So I'm going to share with you just the last 2 minutes, and really the last section here is about home telehealth monitoring. And just let you know that there's many types of devices that could be a real asset to your patients. Everything from blood pressure, EKG, pulse height, weight, and glucose, and other types of measures can be monitored at home. Instruments can be placed temporarily or on a full-time basis. And this is the greatest opportunity in telehealth right now, is to avoid emergency room visits, find out if people have, you know, recurrence for CHF is a huge thing for hospitals and other types of chronic disease conditions. And many of your health centers may where they could help support that type of thing. My last slide is a summary slide, just to let you know that telehealth is here and now. It's not the Jetsons anymore. It's really here, and it's going to be having exceptional growth, and it provides documented efficiencies, cost reductions, and improvement in care. And the rest of it are really self-evident as far as the opportunities for funding, opportunities to do pilot programs, initiatives. You can start simple with telephone and video types of conferencing, and then begin to layer on the instruments that are already available from medical distributors and suppliers that you already work with. And I think it really ties in well into your idea of being part of the community. You know, the future world might look like a YMCA having a health spot, or a community center, or a public housing environment. We are in a very, very early pilot phase with the PHMC group to try to create a demonstration project. And if that comes to fruition, I'm sure they'll be in touch with you, where we could actually place it in a public housing environment outside of near an ER hospital at Temple University. And we're just in very, very early preliminary discussions there. But what I can tell you is the feedback from the Philadelphia Public Housing and also the community center is like, when can we get this? You know, it was like 2 minutes of showing the video. It's like, this is what we need. They want to keep people out of the ER. They can't handle all the patients that they currently have at their health center. So with that, I'll take, we've got 5 minutes for questions, perhaps. Anything that I shared confused you with or overwhelmed you with? Good. Well, I appreciate it. Yes. Okay. Perfect. Correct. There isn't a federally mandate, but there's a lot of what I would suggest government initiatives to move it forward. I think there was that Centers of Medicare Medicaid Innovation. I didn't even realize that was going on, and I don't even know about that group. Maybe you all are more familiar with it, but I mean, there's a lot of initiatives there for telemedicine. Yeah. Questions in the back? Yes. Exactly. Yeah. The question is about the efficiency for the practitioner, and that's probably one of the most important deliverables with telehealth. Is there's times when practitioners aren't busy and are available to see patients. I'll give you a good example. We do consulting work with retail clinics, and their break-even point is about 14 to 15 patients with retail clinics. 70% of them are losing money because there's times when nobody's there. They're watching the paint dry. So they're looking at this as a model to say, hey, while my person's in Cleveland, Ohio, I could be seeing a patient in Cincinnati remotely. They could have a video camera and me doing this type of care if they had that clinic there. The same would apply for your opportunities as well. It's really the ability to get providers to be working at the top of their license and providing a more efficient model for them to actually deliver care in a more cost-effective model as well. Correct. Yep. Yeah, the states are controlling, so they only want you to treat patients within your own state where you have that licensure, and that was the new law that is proposed in Congress, which they believe, rumor has it, is going to change, where practitioners don't have to be within that same state to be able to treat those patients. And also that first patient visit, that's another barrier that only 14 or 15 states allow that. So if it was in a Walgreens or a YMCA, let's say, that you had that health spot unit, you wouldn't be able to go in there unless the nurse practitioner or PA was one that you already knew from a prior part of their practice. And that may be something that may change as well. In your model, in the health center model, I don't know that would be as much of an issue, but maybe it would be. I don't know how that works. So, but I think the idea of having practitioners operate more efficiently and bringing in specialists. Many times, my suspicion is there's times when you would like to have better access to specialists within the health centers, and this gives you that opportunity because they could be remotely. So you could have that dermatologist or radiologist or that psychiatrist or that other practitioner at a remote site at their office somewhere and be able to provide that care right into your clinic, which would be a huge advantage, just from an efficiency standpoint as well. Yeah. Question here? Right. Yeah, that's a very good point. What I can share with you on the private pay side, where a lot of this technology is obviously going with employers and that type of thing, one of the largest payers, one of the second largest payer in the country is reimbursing for this telehealth experience that you just saw with both Optimized Care Network and the HealthSpot at the same level as a real visit. So they're looking at it as the same as a regular office visit. So they're of the opinion that this is the same level of care. So there's no GT modifier from the private payer standpoint. So they already are sold on this technology as providing better access for them because they know that on the back end it's going to save a lot of costs and provide better care experience. So good. Well, any questions? I'll leave you my business card and I can follow up and bring in some other experts that we're working with. We have a team of consultants that are helping us in this space. And then our presentation, I'll make sure that it gets posted with you know, the coordinators, and make sure if you have any questions, then you can take a look at it then. Thank you very much for all your time. Appreciate it.